All right, let's jump right into this explainer. We're taking a massive, dense 39 medication study packet, specifically Section 11 of the Maryland Protocols, and turning it into a high-yield visual map. The goal here? To help you, as a paramedic student, memorize the 2026 Maryland EMS protocols absolutely cold. We're going to focus heavily on those critical indications, the absolute contraindications, pediatric dose ceilings, and give you the real-world study hooks you need to recall these details under immense pressure. To make all 39 of these medications truly digestible, we're totally ditching the traditional alphabetical list. Instead, we're grouping them by the actual critical calls you're going to run. So we'll start with the cardiac arrest core, move into heart rate and rhythm, tackle respiratory and allergy rescue, look at sedation, seizures and pain, unpack your medical emergency toolbox, and finally end with a rapid-fire protocol self-assessment to test your memory. Starting things off with Section 1, the cardiac arrest core. This is your high-stakes resuscitation pharmacology. We're kicking off with literally the highest-stakes scenario in EMS, the cardiac arrest call. These are the medications you simply must know by pure muscle memory. You've got your primary arrest trio right here. Look at epinephrine. That's the absolute cornerstone. Notice the strict 4-minute cycle for that 1 milligram push. A great study hook here is epi every even number. Well, every 4 minutes, anyway. Then we have your antiarrhythmics, amiodarone, and lidocaine. The crucial takeaway here is those maximum dosing ceilings. Amiodarone maxes out after that second 150 milligram dose, and lidocaine caps strictly at 3 milligrams per kilogram for both adults and pediatrics. Why that hard ceiling? Because pushing past 3 milligrams per kilogram risks profound neurotoxicity and refractory seizures. You've got to lock those ceilings in your mind. Now, for special cause arrests, you need to think about your H&T reversible causes. This is where you quickly recall your specific electrolyte and buffering agents. We've got sodium bicarbonate at 1 milliequivalent per kilogram for suspected acidosis or hyperkalemia. You've got calcium chloride for calcium channel blocker overdoses, and magnesium sulfate, 2 grams over 2 minutes, specifically for torsades de pointe. Now, a really quick clinical pearl straight from the source. Never, ever mix calcium and bicarb in the same line without a solid flush between them. If you do, they will literally precipitate and form chalk right in your patient's vein. Moving right along to Section 2, heart rate and rhythm. We're talking rate control and pressure management. Let's contrast two completely opposite action drugs. For symptomatic bradycardia, atropine requires spaced-out dosing, half to 1 milligram every 3 to 5 minutes. But adenosine demands an immediate, rapid push and a fast flush for regular narrow complex SVT. It has a half-life of less than 10 seconds, which is incredibly fast. So remember this hook. Atropine takes its time, adenosine needs a slam. And always prepare your patient for a brief moment of asystole with adenosine. It's essentially a Control-Alt-Delete for the heart's electrical system. Notice the strict protocol guardrails we have going on here. Look at diltiazem, our calcium channel blocker used for rapid AFib. It is absolutely strictly contraindicated for pediatric patients under 18 years old. No exceptions without a pediatric base station consult. We also see esmolol in the 2026 protocols specifically for persistent VFib or pulsus VTAC, but only after your second amiodarone dose. And then there's dopamine, your pressor, which is titrated to a systolic blood pressure of 100. Just remember to always correct hypovolemia before you even think about starting that dopamine drip. Next up is Section 3, respiratory and allergy rescue. This covers your bronchospasm and anaphylaxis protocols. So, this category tackles those crashing respiratory distress and anaphylaxis patients where seconds absolutely matter. The crucial point to master here, and honestly, this is tested directly in your final self-assessment, is the vital distinction between your epinephrine concentrations. The 0.1 milligram per milliliter formulation is your standard IV or IO concentration for cardiac arrest and profound shock. Contrast that directly with the 1 milligram per milliliter formulation, which is your standard intramuscular concentration for asthma and anaphylaxis. A fantastic study hook to remember. 1 milligram per milliliter is one big punch to the thigh for allergies. Never mix these up. Giving that 1 to 1,000 concentration via IV can cause massive lethal arrhythmias. Grouping these bronchodilators together reveals some super important age ceilings you just have to memorize. Albuterol is pretty standard, but the pediatric dose halves to 1.25 milligrams if the patient is under age 2. Ipratropium, which is so often given right alongside albuterol, is completely contraindicated for infants under 1 year old. And terbutaline, given IM for severe asthma, is contraindicated under age 12. So your pattern recognition hook here is simply 1, 2, 12. Ipratropium under 1, albuterol halves under 2, and terbutaline is out under 12.
While diphenhydramine provides immediate H1 blocking antihistamine relief within about 15 minutes IV, dexamethasone acts as your long-lasting steroid. Just a quick clinical warning on the diphenhydramine, though. Pushing it too fast IV can cause a sudden, really dangerous drop in blood pressure and profound drowsiness, so make sure you push it slow. Meanwhile, dexamethasone actually modifies gene transcription, providing a biologic effect that lasts up to 54 hours to prevent those dangerous late-phase inflammatory rebounds. They really act as a team. Benadryl fights the current fire, and Decadron prevents the reignition.
Moving on to Section 4, sedation, seizures, and pain. This is all about managing the central nervous system.
Next, we're grouping the medications that directly alter the patient's central nervous system, pain perception, and seizure activity. Pay really close attention to the protocol hierarchy here. Midazolam, or Versed, is absolutely your first-line benzodiazepine choice for seizures and agitation. But look closely at diazepam. Paramedics and only use diazepam for an active seizure without consultation if midazolam is completely unavailable. And then we have ketamine, a powerful dissociative. The Maryland Protocol explicitly states that if you use ketamine for severe agitation, transport requires 2 clinicians in the back of the unit. That is a major operational rule to keep in your back pocket. When it comes to managing pain, you really have to memorize these specific guardrails. Fentanyl and morphine both require an uncorrected systolic blood pressure of at least 90. You might wonder why the blood pressure floor of 90. It's because both can cause systemic vasodilation that will completely tank a borderline patient's pressure. But look at your non-opioid options. Ketorolac, an NSAID, is strictly contraindicated in children under 2 years old, as well as anyone with bleeding risks or head injuries. And acetaminophen is contraindicated for infants under 3 months. You always have to respect those age floors. Section 5 is the medical emergency toolbox, where we look at reversals, antiemetics, and cardiovascular support. This section serves as your overall medical toolbox, covering a massive range of calls, literally everything from hypoglycemia to hemorrhagic shock. For your sugars and reversals, pattern recognition is key. Dextrose strictly mandates a glucose recheck after dosing. Glucagon, which we use for both hypoglycemia and beta blocker overdoses, is actually completely ineffective if the patient's hepatic glycogen stores are depleted. So think of your malnourished or chronic alcohol use patients. And here is a massive pediatric red flag. Naloxone is entirely contraindicated for neonates under 28 days old. If a newborn isn't breathing, manage the airway. Do not push Narcan. Looking at your cardiovascular and shock tools, you really want to flag that strict limit on lactated ringers. You absolutely must get a medical consultation to exceed 2 liters of fluid, which prevents fluid overload. For TXA, it's got to be given within 1 hour of injury for hemorrhagic shock. For nitro, you must aggressively recheck blood pressure before and after every single 0.4 milligram dose to avoid completely tanking their pressure. Remember, these aren't just suggestions, they are the protocol. Grouping your behavioral and antiemetic meds together exposes a shared critical adverse effect. Ondansetron, droperidol, and haloperidol all carry the very real risk of QT prolongation, which can, of course, lead to torsades de pointes. Furthermore, both droperidol and haloperidol can cause frightening extrapyramidal or dystonic reactions. Listen, this is a life-saving field tip right here. If you're giving Haldol or Inosine, always keep Benadryl nearby because diphenhydramine is the exact antidote to reverse that dystonia. Rounding out the toolbox, we have some highly specific interventions. You have labetalol for severe pregnancy-associated hypertension or stroke alerts, cephalicin for open fractures, but I really want you to look closely at activated charcoal at the bottom. This acts as a giant red flag in the protocol because it absolutely requires online medical direction to administer. Never, ever give it on standing orders. It's a huge airway risk if the patient's mental status changes. Finally, Section 6. Final protocol self-assessment. It's time to test your pattern recognition. Let's see what actually stuck from this explainer. We're replicating the study packet's self-assessment to force you to actively recall these protocol patterns. Question 1. Which medications require blood pressure monitoring before and after administration? Think back through everything we just covered. The primary answers are your vasodilators and antihypertensives. You must rigorously check blood pressure before and after administering nitroglycerin for chest pain and labetalol for severe hypertension. If you push these blindly, you risk totally bottoming out your patient.
Moving on to question 2. Which medications require a medical consultation for initial or repeat dosing? This is a massive safety hook. Remember that activated charcoal always requires a consult. A third dose of labetalol triggers a consult. And, as we saw with shock management, exceeding 2,000 milliliters of lactated ringers triggers a mandatory medical consult. Knowing when you have to pick up the radio and call base is honestly just as important as knowing the dose itself.
All right, question 3. Can you name the medications with strict pediatric age contraindications? Test your memory on those strict pediatric ceilings we mapped out earlier. Diltiazem is completely out for anyone under 18. Droperidol for agitation is a no-go under 13. Ketorolac is contraindicated under age 2, and naloxone is strictly contraindicated under 28 days. If you can memorize these floors, you'll avoid major pediatric medication errors in the field. As we wrap up this explainer, I want to leave you with a direct quote from the study packet itself. The local/current protocol, medical direction, and medication label always take priority over the study document. While this visually maps out the 2026 guidelines, your local medical direction is always the ultimate authority in the field. Mastering pharmacology isn't a one-time event, it's a career-long practice. So look at your protocol book right now. What protocol detail are you going to review next?